and assistant in charge of intensive care unit. And now I invite the person who's going to lead the book, the sciences. Dr. Naveen. Dr. Naveen silence is. Thank you. So he is the head of the advanced cancer advanced Center for Advanced Research at KMC Manipal, and professor of palliative medicine from KMC Manipal, and very well-known international researcher and academician. So he will be here in a few minutes. In the meantime, I'll give the mic over to Bhavna because we're going to do a small exercise while this panel discussion is going on. So you are going to be doing some work while you're listening. Okay, so over to you, Bhavna.
And thank you to our esteemed panelists. I'm very excited for the rich example of where the system will improve. So if you go into your workbook, the one that's on the file we showed, so that you are working on. So I think page 11 or so, there's a this exercise. So as we were describing, your data point is qualitative description, and that comes from individual or group discussion. So this panel will be like your focus group discussion. So listen to each line intensely. Now that page 11 has a rubric which you can use to guide yourself on like barriers, facilitators, areas of conflict or struggles, and more. That you can start to take each line by line and start to see which fits into which element of CEPR now that you've gotten a little into the CEPR framework. And I'm going to hand it over to our qualitative research experts, Dr. Priya Thomas.
Thank you. Thank you. I'm not an expert, but then we have been working on quantitative research. So what we would like, as Dr. Bhavna said, this is going to be our focus group. The panel is experts. If you remember our focus group definition itself, it is a group discussion which is focused on a particular very important topic that we are interested in finding solutions for. And we put together stakeholders who also, if you would remember Dr. Sarkar's session today, he was talking about who defines the problem, who can tell us the magnitude of the problem, and who can give us the solutions. That's what we are going to be on the lookout for in this panel. So this panel will be our focus group. So methodologically, many of you may be familiar with focus group decisions. Consider our panel as having a guided discussion on the identified research area that we have now spoken about. And all of us as observers, when we listen to them, we are going to note down what is happening there. So two ways, right? All of us know that sometimes we audio record, but sometimes we can also write down. So we are going to write down now what is happening there, what each person is saying. So please make sure we are also identifying the person who is speaking when you are writing down in your notes. And from that, if we can fill in our rubric, which we have now given. So we are talking about whenever there is a statement that comes out that is talking about facilitator, let us identify that and let us look at the quotation that has gone with that. So that is the rubric. Is that so? That is, we are not going to be the observers and we note takers. You are going to take the notes now, and from there we will identify. At the end of it, we will actually have a very rich data which has come from all the experiences, which we will work on towards for our next session. Any doubts? Yes. Any doubt? Any so let's listen to them. Listening is very important. Also, if we can look at the nonverbal communication circle. So in a panel, it may not be a very important thing, but it will also help to give some more strength to our findings. We are able to also bring in our nonverbal expressions and something like that. So also, if any other So the rubric highlights facilitators, barriers, contradictions, certain themes that are coming out, or anything else that you find that's emerging from this conversation, please capture it. That is the plan. Right? So let's do it.
If everyone's been able to find this sheet that Dr. Bhavna was talking about, it's the panel. Yes, so the panel recording sheet is on one of the pages of the copy of the workshop workbook that's available, followed by a panel recording kind of table which talks about facilitators and barriers. So you'll find it there. I can come if you've not been able to find it, and then we can start the discussion.
Are you able to?
Yes, sir.
Confident introduction of this.
Okay.
Then we'll off mute and we'll try to put them off mute. Then I'll start it on Monday. What?
So we had a panel discussion on
I'll just call you back.
barriers to integrating palliative care in scientific setting. It will be led by Dr. Naveen Saris, who is the overall in charge of the Department of Palliative Medicine and the Center for Advanced Research at KMC Manipal. Dr. Ashwin Udupa is an intensivist from Manipal, Bangalore. Dr. Pratyasha is palliative care physician faculty at the Department of Palliative Medicine in St. John's. Dr. Anuja is professor of palliative medicine, Department of Palliative Medicine at KMC Manipal. Sister Sara is the Chief of Nursing Services of St. John's Medical College Hospital. Dr. Bhuvana is the head of the Department of Critical Care at St. John's Medical College. We are expecting one more person, Dr. Sister Lavina, who is the nurse in charge of intensive care settings at St. John's. So I think we can begin. And Dr. Somnath Chatterjee, who has kindly joined us online. He is the director of Prathriya Hospital in Bangalore. From the administrative perspective, we'll be hoping to hear from him. He's an intensivist by background and currently the director of the center. Thank you.
So, good afternoon, everyone. And, thank you, Nandini Madam, for making this introduction. And we have a very esteemed faculty in the panel, and those faculty have been introduced already. So, I was looking at the theme, and theme in this panel, what we want to achieve in this panel. In this panel, we would like to see in terms of what facilitates or hinders or what enables upstreaming palliative care in the intensive care. So this is what we are hoping to achieve in this panel. So we are going to take the views of all the stakeholders. So all of them here are the stakeholders. We have one stakeholder missing, that is our patients and families, because they are also the end users of this service, and that's their views are also very important. And if we look at this whole panel or the whole workshop, if we take from an ICMR's perspective, they use this term called 4D approach, where it is discovery, descriptive, development, and delivery. So I'm taking away the discovery and looking at the three parts, that is descriptive, developing, and delivery. I'm not going to focus on all three parts. I'm going to focus only on the delivery part of this. Because if you look at describing something, when we say describing something, we know that the palliative care is needed in ICU. We know its benefits, we know its outcomes. And there are several literature already available, both from India and overseas. So one of the examples could be one of the scoping review that was done, which was published in Journal of Critical Care from the low middle income perspective. There was a theory of change paper which was published again on how to integrate palliative care in ICU. So there are a lot of things have been described. And from a development perspective, this entire car grant that what we have, which St. John's is a vital partner of the entire car grant, is we are developing an appropriate care package in the ICUs, which is being developed using evidence, using stakeholders, conducting real reviews. But I'm not going to either of them, neither descriptive or into the development, but mainly from a delivery perspective, because this whole conference is underpinned through implementation research. With that, we will try to take the views of all the stakeholders to see how we could effectively deliver palliative care in ICU. So, to start with, I will start this panel with two intensivists, Dr. Ashwin Odupa and Bhavana Madam. So I always feel that the ICU physicians are the gatekeepers. You are the key decision maker. You are the primary caregiver in the ICU. Everything often revolves around the intensive care physician. And you have a duty of care to both patients and families. And also, you always try to see what is in the best interest of the patient. And I assume that you have a reasonable idea when you are managing the patient about what this illness is, what is the course, what might be the expected outcome, what might be the benefit, what might be the harms of that. And you also have some idea about policies that are existing, processes that are there. And you also work in the systems, all the panelists, where palliative care team is available. Now, I will start with Dr. Odupa. In your previous avatar, you have worked at Manipur with us. So, with this background, what do you think that would be the key enablers that would ensure appropriate care for patients in ICU?
So I think the awareness of the doctors, including the intensive care physicians and the co-managing doctor, say for example, general medicine, their acceptance that, or oncologist for example, their acceptance that this patient is now gone so unwell and critically ill that he will benefit from a palliative care effort. That will be the first step of understanding knowledge. And availability of a palliative care team service in that hospital, which can be facilitated by the institute head, is probably the biggest step forward to inculcate the palliative care referral patterns.
So, if I understood, two things that came out from Dr. Udupa is A, the service has to be available, and B, the ICU providers should be aware about the service and the scope of the service. Okay? So, in both the centers that what we are working, where the CARNET is active at Manipal and in St. John's, there is a palliative care service that is working very closely with the ICU. So, I would ask the same question to Bhavana Madam. From your perspective, to deliver palliative care in ICU, or maybe term it differently as what is appropriate for the patients in the ICU and doing what is right by the patient. What do you think would be the key enablers?
The awareness of this, they should be comfortable with the concept of palliation, because as you all realize that medical field has advanced so much that endlessly prolong patients on multiple life supports. I think the awareness and the comfort with which they can accept and adopt palliation, and definitely, as Dr. Ashwin said, the availability of services so that it is an easy transition from aggressive ICU care to palliation. Even before, if I can say comfortably and confidently, that even before the palliative departments have been established, the hospitals as intensivists, they were always doubling up as both
as an ICU physician as well as transitioning to a palliative, that's what I was discussing. Because still many hospitals are, not having the luxury of a palliative department. So if the intensivist has the experience and can transition from an aggressive intensivist to a palliative physician, that means he has accepted it and he's comfortable with the concept and he's aware of the processes and the policies, so he can transition. And if there is an availability of such a service, definitely, it is added advantage to have a more smooth process. I feel that is the most important thing, the awareness and the comfort and the knowledge of what is palliation, how to bring about these steps in the ICU.
So, since both of you have brought awareness as something that is very significant, how do you think we could make the ICU providers, when I use the word providers, it comes everyone who is there in the ICU, doctors, nurses, and all the stakeholders, aware about palliative care? What do you think we could do practically on the ground to make that happen?
Probably a reflection of cases that they have managed and how they felt. It's like a debriefing sessions or on ground or in the field itself. What else? Awareness and once you have
I think education and in addition to the workshop, so we are now looking at tomorrow's generation of intensivists who are going to get trained and come back. Maybe include a small leaf of palliative medicine in their training period so that they are open to that idea to understand that it's not just terminal kind of care the last 24 hours, but it's much before that. And it's more of laying of suffering. That is the whole idea of palliative medicine rather than just terminal illness care. And also maybe removing the stigma on the word palliative, like name yourself as supportive care or something of that sort, might help us intensivists also to sell the branches that we're not actually doing something enough right, but we're actually improving their quality of life in the remaining days.
other thing, religious leaders also, because a lot of their palliative decisions are based on what is the religion that is supporting this idea. So that can also in the community awareness also, I think, to religious leaders and probably awareness in the community for different other means also would help a lot. Not just looking at the physicians and even probably the community.
Just to add another layer to this, a lot of things I know about intensive care friends who are very much algorithm based or very protocol based, and most of the protocols gives you a framework on which to operate. Do you think that integrating these aspects into those algorithms, frameworks to which would probably give like a trigger or a way to suggest that maybe this is the point, this is the trigger for considering palliative care, or this is when you are providing intensive care therapies for a certain period of time, and this has been the trajectory within the ICU, and these are the triggers that should herald probably and refer to palliative care. Do you think that very pointed, focused education rather than a very generalized palliative care education would help? Just a thought.
But it may be an endless, we don't know what and all you will have to put in to say these would be the triggers. It could be an endless list too. But definitely for someone new and not yet comfortable, young intensivists, it may be useful to train them on and okay, use these tools to prognosticate. But I think there's a lot of gray area there, not very clear black and white to objectivize this, the framework for prognostication is my opinion. I know there is something that's coming up and we're working on with regards to the ICMR to objectivize the prognostication. But this is my feel on this.
I would advocate empowering the nursing team from initial district. Actually, the nurses are probably more acute thinking and aware about the suffering of some of the patients, where the doctors are tuned to provide the algorithm, and I don't think there's an algorithm for palliative care initiation. It's more of a subjective impression of how the patient is doing and whether the patient is suffering or not. And that, just like a med call, palliative care call, I think that is triggered by the nurses. I mean, that happens in most of the, I'm sure, the Western countries. It's the nurses who initiate that this person will benefit from some comfort care, including the ICU patients. There will be the senior nurses who will take the doctor or consultant away and take it up. Just let the person.
And I'm sure that happens. Yeah. One thing which Dr. Govana kept telling, it's a word that I call, is be comfortable with this. So, can you explain a bit more about what is be comfortable with this? Because we have ICUs with different levels of maturity, and the ICU providers with the different levels of maturity. What do you probably can expand on that a bit?
I think we need to have experience and who have gone through it. And it's not that we are not human beings, we are not robots. And when we experience, there are emotions that come from our side, also not just from the person who. So we as a team, when we go through this palliation, is as a team, not as a patient and just the family. So when we have done it and we feel it's like we close the entire scenario with the family coming and thanking us how they felt, and then you feel confident, oh, this is how we've done it the right way. It has given the kind of closure for the family side on this patient's suffering. And then you get confident and comfortable. Yes, this is what we do. And yes, I feel the comfort also comes in with the legal backing. Okay, this is what even the law in India says. Western, I can't use Western picture at all in India. What we go through is a totally different ball game here. So what India and the court has to support us and gives another extra added comfort there. So I think someone in the team has to be the start who has to do it. And the younger generation joins it, they get comfortable and they are the future leaders on this. So its comfort is to be in such a scenario. Then even the nurses, the team gets comfortable. I'm sure now my team in the ICU, they're very comfortable with withdrawing. We go through the primary medical board, secondary medical board. There is no, otherwise we would have more moral, burnout than we would expect. So I feel that's where I think.
That's right. And also, if I could rephrase what you just said, is that you are very experienced, you have done it, you know it, but your junior doctors in the team probably they having that imbibed learning is also an enabler, probably, isn't it? For them to make comfortable, for them to be comfortable with what's happening. Yeah. So, in the same breath, what might be the current barriers that you might be facing right now? So, we talked some about the enablers, that awareness, being comfortable about it, availability of the service or enablers. But what could be some of those key barriers which you still feel that, okay, we have reached so much, but we could still reach to a next level if we could address these barriers? You can start and then I'll ask a question.
I feel the knowledge of valuation is not uniform across our own fraternity. So it becomes very difficult when we have to start the initiation of valuation in the ICU. When the time is very short, and if it would be good awareness and the comfort which I talked about should be there across specialities. So that is one of the knowledge and the comfort across, not just in the ICU, I would say even before the patient comes to the ICU from emergency or other departments. So that is one of the barriers, knowledge and comfort. Other than the ICU is what I would say. I'll probably give it to others too.
I will ask, a set of questions for that. There is a stigma with the referral hospital, which I have noted, which to an extent from the treating clinician was spent a lot of time with the family and just do not want to give up on the possibility of a cure. I think that is the biggest barrier, and that probably is not going to go away, to be honest. So, associated with that is the stigma that once you refer to palliative care, that means I have lost it. I have given up on the patient. I think driving the stigma away is probably a very crucial. So I'm interested because you use this word 2 times, the word stigma. What do you actually mean? One of the things you have provided an explanation that referring to palliative care means that maybe the doctors have given up, kind of a thing. That's a perception. But apart from that, are there any other connotations? And how are you addressing it in your plan? So, if I want to break it down to the clinician and the family, first of all, I try to address their issue of what is the barrier. I mean, if you're thinking that it's going to benefit the patient, definitely we should go ahead and do it. And the family also, I would explain to them that we are not going to put an end to this. What we are trying to do is to facilitating so that the person who is there is not in pain or suffering while we continue the treatment. This is how I address and talk to them and put that understanding which I have about what the palliative care specialty is. But anything you want to add to the term stigma, and how are you encountering it and how are you addressing it?
I mean, this motion is there amongst us also. We are worried that if we send out early referral to palliation, how would the family who we have built a rapport think? It would be an unspoken feeling like, okay, has the team given up? So I feel the family who we have built a rapport and they've had the trust with us, and when they're still looking up to us to see, are we going to give them some hope and somewhere here until they have come to consensus, okay, yes, we have realized our patient is suffering, and then we introduce the palliative referral. Before that, we could still have the stigma of whether are we giving up even before having a good period. A time-tested trial, yes, but how long this time-tested trial is very, very individual based which patient for how long. So has the doctor reached a point that we have reached the time-tested trial and we conveyed it to the family saying, yes, we've reached a point of nowhere. Until then, before that, you send a reference, there is a possibility that that stigma of yes, we've given up may be there. I wouldn't use the word stigma. This is a feeling that even we would be keeping and would be cautious about it.
I always speak about sequential versus simultaneous care. Now, often it is considered as sequential care. That means my care ends and their care begins. It's a sequential care. Simultaneous care is, where my care is continuing, but their care is added to that.
Our care, we do it together. Even it's not that we stop caring, it is there, it continues, and then there's another team that is coming and added on to transition. So that continues. That is never like we give up and we don't see the patient at all. Actually, we spend more time with the patient who's actually going to be transitioning to palliation. And we realize that in the ICU, ours is a very busy ICU. We sometimes spend more time with that patient than some of our sick patients who we can actually be giving more quality time. We will be, cutting short. That is something I need to own up because that is, we realize we have had multiple counseling sessions and the family still needs us. We don't try to compromise that and we'll definitely say yes, stabilize this patient and come back. I'm coming back to speak to you.
Sometimes the simultaneous care is actually doing more than doing less, actually. As your right is
The simultaneous care, I just wanted to say is when the simultaneous care, the timeline starts in is what I thought I wanted to convey what I was saying.
Thank you. And next question to you. Suppose we all have everything in place. We have an excellent palliative care team integrating with ICU. What would success looks like? What an ideal successful integration from an ICU care provider looks like?
How we would look at the outcome.
Outcome. So suppose you want to say that you have it, all ICU providers are aware, which you said. You have a good palliative care available, they are integrating, you have addressed a lot of barriers, and you feel that okay, now we have a very successful. So if you look ahead and see what, according to your mind, what success looks like.
See, the entire team is happy and including the family and has felt happy at the end of the, that whatever that instant, I think that is the best.
So if the providers and family are satisfied.
Satisfied and you feel good. There is no guilt that goes on at the end of the patient's end. I think that's the best that we have achieved.
So
I would probably sequentially add what I just said. So I would agree with Dr. Govardhan that most of the if the patient and the caregivers and the clinicians are satisfied with the care they have given, and in addition to the palliative care team and intensive care team, I would call that success. And also visibly, if the patient did not suffer, and towards the end of life care, the facilitation, and often there are lots of issues which come up with specific to palliative phase of the illness. And if that final phase was spent in a painless manner and without life, without much of a too much of distress, I would say that is a success. So, for example, suppose the patient spends such an amount of time in the ICU and then goes to the ward. There are a lot of time when you spent in the ward with issues related to end of life, such as constipation, etc., which if that all of them has been dealt in a meaningful way and the best possible way, I would call that a success.
the reason I asked this question is when we did the theory of change workshop and the looked at what is the impact of ICU palliative care integration, what outcomes would lead to this impact, and what interventions we could develop to develop those outcomes which leads to the impact. So I think envisaging what in your own mind as what that success or what you really feel as an impactful engagement, maybe always have. So thank you both. I'm going to Sarah Madam and Ravina Madam. So while ICU physicians are providing the care, I think you are the one who manage the ecosystem, let's say, of the ICU. So it's a very important job or a description that you have is to manage the ecosystem. So you are actually the front line. Physicians come and go, but you are there all the time, front line. You are the one who are in direct line with patients and families. So you want these services to be provided in a very smooth way, in a way that is very satisfying for the families, And as much as doctors, you also know what's happening there, isn't it? How the patient is progressing, what might be the likely outcomes. And also you want what is best for the patient, And you also probably aware about some of those policies or the processes that are in place. Now, on this background, from your perspective, what do you think that would enable a better palliative care engagement in the ICUs?
First and foremost, sir, actually in the counseling section, when the doctors are counseling the attenders or patient relatives, we are not much involved. So we may not be knowing how to console the attenders, patient relatives. So if it could have been done, like if we go for counseling, sit with the doctors and the family, it will be very helpful for the bedside nurse as the treating team also, because we are not much involved in the counseling. As a bedside staff, the staff will be taking care of the patient and providing comfort, care to the patient. She knows what to do. But ultimately, when the relatives comes to the bedside, the doctors may not be there at the bedside, but the bedside nurse will be there at the bedside, and she should be able to tell them what is happening. So the bedside nurse also should be involved along with the counseling team and the doctors. So that will give the proper knowledge to the bedside nurse and make them to make the relatives to understand what is happening. So most of our nurses are the new nurses. So we are training them. We have trained them. And in those situations, the family is very panicked. Family relative attendants are very panicked, and they may not be able to understand. Even though doctors are explaining in the council, they come back to us and what is going on with the patient and how do you take care of these things. So we need to explain to them, and we are doing it. But if we involve in the counseling session, it will be better for us to give more comfort to the patient family.
I will add on a different line. I'm going through a different line in fact. I would start off with looking at what is the philosophy of life. Each of my nurses, what are they thinking of life itself? And especially in a Catholic institution, when we talk about respect for life from womb to tomb, I'm not sure what their mind is thinking there. I think that is something we need to really think of, because they may not voice it out, but somewhere deep inside that may be a question that comes whether, like how Governor mentioned, the religious connotations to this, government has put rules, but then the individuals' religious beliefs, spiritual beliefs, when they are in that team, also I think not just the awareness of all these things, but much deeper inside. I think that is also important to think of, because they have been taking care of that patient so long. And suddenly, when I'm not saying that moving to palliative care is wrong or anything, but then to make them understand. And if you look at today, our bedside nurses are just raw, fresh nurses who come out of school. I should thank Nandini ma'am and others who worked out to put that palliative care concept into our curriculum. In fact, in the semester curriculum, I should congratulate them for that, because from, like how Sir said, for medicine in nursing curriculum that has come in now. But how much is that concept driving into them? I think is a question that we still keep asking. And also, even if it is not palliative care, also some of them are facing death for the first time. What is the psychology behind it? That guilt, especially in Indian culture, even not only for the healthcare workers, even for the family. There may be family members who come back and say, was it right? Will that spirit still stay on? Is that person at rest now? These are other questions that can be asked also to healthcare members. So the counseling, to what level is our counseling? How do we make the family, every member of the family understand this concept and take away the guilt finally, so that the person is moving on, but the one staying back should not stay back with that guilt.
So, two important aspects came out of this is empowerment and conflict. The one aspect that you spoke about is nurses are not empowered as a stakeholder, and they're actually the vital stakeholder. But as a stakeholder, to be part of this family meeting, the purpose of this family meeting is communication, providing information, decision making, which will change the course of the disease. So they are not being part of it, and that's one of the. So they being part of it would be an enabler. Yeah. And second thing is,
with this, I would also add, do we force the nurse to be part of it? Or does the nurse have a choice to be part of it? I'm sorry, I'm raising questions like this, but then
no,
that is the truth at the bedside.
We may put down policy saying the nurse has to be, but what about her? What is her? Because I recently spoke to a senior nurse who said that time, okay, palliative care and all wasn't there, but she said a GBS syndrome patient reached there and I had to pull out that tube from that. And I still, that eyes of that patient looking at me still haunts me. That is 35 years ago.
That's fine.
So how do we enforce and say, yes, nurses need to be empowered and they should do it? Or do we give a choice for them?
Of course, it has to be with choice basis.
Yeah. So then, how do we empower them to make sure that they can be in the team? Because I'm not sure if our young nurses will be able to cope with it. I'm sorry to say. So then, do we have another team who are experts or able to, but they will not be at the bedside then? And the number of nurses, I'm sorry, but meaning if that nurse from that bedside has to come to the counseling room and say, who's going to take care of the patient then? Because our numbers also are concerns.
A lot of pragmatic
Critical
considerations.
concerns are there.
Other important point that you also brought up is conflict. Two conflicts. One is role conflict and religious conflict. Okay? Role conflict is, well, as you mentioned rightly, as a nurse, my role is to care or to cure or another perspective they have. And sometimes withdrawal of life support may be a role conflict. Second one is the religious conflict, where preservation of life, if based on certain religious principles, if it is contradicting to that. So, as a nurse administrator, how are you addressing these conflicts?
Yes, awareness that these are changes coming up. And second is to take away the guilt feeling. I don't know how to do that because many times people may not voice out their inner thoughts and worries and things like that. But then to give a forum where they should be able to ventilate or have a small group sessions where debriefing for the healthcare workers, not just for the parent, for the family, but also healthcare workers so that they can also ventilate their feelings on things like this. It's what I would think. I should apologize that in St. John's I have not brought a forum like that yet. But I know there are many who come to my office one-to-one where we have issues which are sorted out and try to help them out to the extent that we can.
Thank you both for your valuable thanks. Now I move on to the hospital administrator, Subramanian sir. Sorry, Somnath sir. I know you are also an IC physician first and then the administrator next. And as the administrator, you want to bring good operational efficiency. Average length of stay is very important in the ICUs because that will bring in that operational efficiency. It also has a bearing on the revenue. And ICU resources are precious. I know in my own hospital, at least 5 patients are turned away each day because there are no ICU beds available. So, within this framework or background, what do you think would enable a palliative care integration in the ICU that would enable the right care for the right patient, or what you call the appropriate care? And from an administrative perspective, what do you think would be those key enablers? I think your voice is not heard. This one.
I hadn't switched on my microphone. I'm sorry. Thank you, Dr. Salins. Are you able to hear me?
Yeah, now I can hear you, sir.
Thank you. So, as you said, I have 2 roles. I have 2 avatars. One as a critical care physician, as well as that of an administrator. My personal belief is that our responsibility lies to being able to provide the right care for every patient who is already past our door. So the existing patients in the ICU have to be given the right care. And if that care is palliative care, then so be it. Now the question comes, I think from that perspective, it's that the enabler, the most important enabler is where the entire organization, which is across the departments, this could be, neurosurgery, this could be um, oncology, all of them are aware of palliative care, and a palliative care reference is taken very early in the care of the patient as to whether, if there is any doubt, a reference is sought. And the important thing is, if it's inappropriate to admit a patient and put them through aggressive ICU care, then that should be communicated to the patient well ahead. And I think the best way to prevent patients being turned away from ICU because there are no beds is to have reasonably strong gatekeeping at the ICU. So, and that gatekeeping is not forceful, but is managed by good teamwork among ICU physicians as well as physicians on the wards and in the rest of the hospital, who will then communicate with the family along with the palliative care team and convince the patient or do what is right for the patient, and if possible, avoid unnecessary admissions to the ICU. I think that's the most important thing. And the other enabler is extremely good relationships in terms of good communication between the patient as well as the patient's family and the clinical team. Obviously, the nursing team is part of that clinical team. We have found it very useful to have an MSW who also is there every time. So, it's difficult for clinicians and nurses to spend huge amounts of time with the patient's families. And that's something that the MSWs bridge the gap, and then they are able to put things in concise manner to you when you have more time. So overall, I think investing in a support team in terms of MSW in the ICU who are able to spend time with the patient's family and then help families come to terms with difficult situations. Second is good gatekeeping in the ICU. And third most important thing is an empathetic team who are not forcing palliative care down the patient's family's throat. So that's something that I think is very, very important in palliative care.
Thank you, sir, for your comment. I have another follow-up question on this. Some of the hospitals employ a review mechanism. That means the patients who are admitted in a hospital, maybe some hospitals have a 5-day rule, some hospitals have a 7-day rule, and they review those patients who are there for 5 days or 7 days and have a meeting to see, is it really appropriate for this patient to continue in the ICU? Or should we use this measures helping the patient or not helping the patient? The review outcome could be that yes, it's appropriate and we should continue. But the review also might be a forum for reflection to see that maybe this may not be helpful also. So what do you think about the review, having a review mechanisms in ICUs, and as an administrator, do you advocate for those review mechanisms to be there?
Besides, I personally have not heard of such a mechanism that exists. I have done intensive care for 20 plus, close to 30 years. I believe that gatekeeping in the ICU as well as care in the ICU, that there is this concept, multiple concepts as to whether it's an open. I keep getting asked, is my ICU an open ICU or closed ICU? I say neither. I keep telling people, ICU, my ICU is a collaborative ICU. It's not one doctor who's making that decision. It's multiple teams of doctors who are working together to try to make the best choice for the patient. And I think this thing that you're talking about in terms of 5-day or 7 days happening daily on the ward, or if not once, more than once. Whether this treatment is benefiting the patient, should we try harder, should we slow down? And that's the purpose, that's our day's job. So overall, that's how I look at it. I'm not sure how an external party who has very little idea of and very little relationship with the patient's family can understand the entire dynamics of care of a patient in ICU. Definitely, as an administrator, if I'm not involved in the care of a patient, so for example, today, if I am called in to ask for help regarding a particular patient, it will take me half an hour, 45, 1 hour to get a story, understand what's going on before I'm willing to get involved and get involved in the discussion with the patient's family or with the multidisciplinary team. So it's quite a labor intensive and emotional intensive. It's multiple things. It's just not about dealing with whether the patient's going to survive or not. It's also about dealing with the patient's family's emotions, the stakeholders, and how they are reacting to what is quite often an unanticipated situation, because we are not doing palliative care early enough, is my personal belief. We we're not doing it well enough. It's still very early for palliative care in India, and I think we still have a long way to go. So quite often, we have patients who come who've not had any discussion about palliative care. If I had to give you an example, we have a patient with CA esophagus not too long ago who had the tumor invading the carina and obstructing the carina. A team from a cancer super specialty hospital put a Gaussian graft to try to bypass the obstruction. Further tumors, they put further stents. And this has been going on for 4 to 5 months. And then this patient lands up in our ICU, it lands up in RER. And we were the first one to talk to them about palliative care. This patient was on treatment for well over 6 months. So this is the problem.
I have one more question for you, sir. Again, from an administrator's perspective, there are unilateral discharges against medical advice, often from the intensive care units. And one of our efforts has been to see whether we could reduce the discharges against medical advice from an ICU, because it doesn't look good for the hospital. Is the ICU providers are not happy, families are not happy. So from an administrator's perspective, do you think that having some focused interventions or focused strategy by which we could reduce this rates of DAMAs or discharges against medical advice? What do you feel about it?
So DAMA is a real problem all across India, I presume. And the problem is, what is the cause for the DAMA? One one of the most important reasons today for DAMA is patients not being able to afford the cost of the care in the ICU. And they go from a hospital where they have to pay the bills and hoping to go to a hospital where the care is provided at a discounted cost or free of cost. And that is quite often an important cause for DAMA. The problem is, who's going to take the responsibility of transfer of that critically ill patient? So that is the trouble that quite often we face. And most often when you call it as DAMA, we take a DAMA consent that says you are taking the patient against our medical advice. You are responsible for the outcomes. You've explained death, hypoxia, brain damage, all of that to the patient. But who is taking the responsibility of transferring that patient safely to another hospital? That is where I have a huge problem, and quite often we have taken the stance that we transfer the patient ourselves if the patient's critically ill and they have a chance of survival, that we have transferred the patient at our cost, and our cost in terms not only of money as well as time to government institutions. That's something that we have done. The other question is, DAMA is when patients disagree with you. They're extremely emotional. patient has very poor outcomes, but they refuse to accept your or our line of thinking and lose faith with us in those situations. Again, quite often they will want to go to another institution, and we try to get the institution from outside to come and take the patient wherever they are going and explain everything to the hospital where the patient is going. So Dharma is a bugbear. I don't think we will find a solution for it in the near future, but we just have to make sure that the things we have to make sure that the interest of the patient is kept central. And second is that we are not doing anything out of fear. That
the one population that you mentioned, which is salvageable or having a better outcome, but cost is a factor which is limiting the continuation of care. But we often see also another subset of patients where the outcomes may not be that good. Maybe an elderly, multi-morbid conditions, or having an end-stage organ failure or a metastatic. Even they go down because the ICU team believes that they should continue treatment. So I think in some of those settings, probably maybe an integration of palliative care do have a role where an alternative care could be even suggested in those settings. What do you feel about that?
I just like an explanation of what is alternative care in your thought process.
Yes.
What we have done quite often, Dr. Salins, is if we do believe that the patient is likely to pass away quite quickly, and the family want to move the patient, and we believe the patient will die in the ambulance before they reach either the hospital or they reach, home. We have kind of stopped billing them. We move them to a ward and provide palliative care on the ward. Sometimes we do bill them at ward rates, but that is after we get management approval. So these are some of the things that we have done because I do not believe a patient should die in the back of an ambulance while being transferred out. If the family or the patient should, or the family should have the opportunity to be with the patient while he's taking his last breath. So I think that's what we have done. These are not very costly interventions. If it's a question of a few hours, but even if it's 12 hours, no hospital operates at more than 60 to 70% occupancy. So there's always a bed available where you can palliate the patient.
I agree with Dr. Sumra. We offer the patient who are elderly and about to, well, not real, who qualify for palliative care, essentially, instead of when the relatives say that the question of giving you want to take him home, so that dies at home, so we offer them. There's always a likely possibility sign that it's going to pass away in the ambulance, and you will have witnessed him passing away. It's not that we can offer a controlled, steady, controlled use in a holding and palliative care services.
Thank you both for joining this one. Now I go to the palliative care doctors, two doctors here. Now, as the palliative care doctors, I'm sure you know the need for palliative care in ICU. You know the benefit and what happens when the palliative care is provided as an outcome. You are aware about the policies, process, when it is time, when it is timely, how to engage, how to provide. Now, despite that, there could be few things that could facilitate or few things that could be very challenging. So, what would be those things that are helping in your workplace that you are working? And I'll ask Dr. Pratyash in her workplace what is working, and also what might be challenging in your workplace and in your workplace.
I think I just highlight a couple of things. What could be facilitated is rethinking the very meaning of palliative care, and not only individual rethinking, it's the institutional rethinking of the meaning of palliative care. Because the definition of palliative care does not contain the word death. It does not contain the word end of life care. But we WHO has given a universal definition. We are still stuck on death at end of life care. We need to rethink the meaning of quality of life and distress assessment and distress management. And that is where the palliative care needs to be related. So I think assessing distress is one of the very important thing that enables timely palliative care if we assess distress. And not only correlating with death withdrawal and withholding of escalation. If we associate it with improvement in quality of life, improvement in quality of care, improvement in patient outcomes, caregiver outcomes, as well as provider and system outcomes, then I think that changes the entire scenario. That is one enabler and barrier both. Second, that I would want to highlight is we do implement palliative care in certain centers. I mean, it's very fragmented, referral pathways. But the evaluation or monitoring of that implementation is a challenge because we don't really emphasize on a lot of collaborative research. Now things are changing slowly when ICMR is also recognizing the importance of research in this area. So I think bringing in more local evidence and more local research, bringing in more, local facilitators barriers, and then addressing them with our own solutions is something that will enable better collaboration and better implementation. So that's what I.
Yes.
So I would like to first talk about facilitators again. In St. John's, I'm glad that we have an ICU team who do a lot of integrated palliative care work already. Having said that, I would also say that I've worked in places where ICU people are not aware about palliative care. Like I worked in AIMS New Delhi as well, and then I worked in Bhubaneswar. I've seen stark differences in places. Considering that, as ma'am said, the awareness is not uniform in different branches. As ma'am said, like when the patient comes from another place to ICU, they come with a lot of hope to the ICU of getting cured. But then, as a solution to this, I would like to tell that when it's not like we have to think at one point it's the curative and then stop thinking the curative, go to another section of thinking palliative way. It's not like that. The integration will come only when we think towards the best interest of the patient. So even as an ICU patient, ICU like service provider, when we look at the patient and we look at the best interest of the patient, if we look at the distress of the patient, like automatically the concept of palliative care or the supportive care will come to our mind. So like looking at the barriers, I would again say that the curriculum doesn't mention palliative care. So there's a lot of unlearning that has to happen to even consider about palliative care needs in the patients that we see. I would also like to talk about the problem that Sarah mentioned regarding young people coming and then looking at deaths. So a very important point was told by Dr. Anjana also that palliative care doesn't talk about death. It talks about improving the quality of life. But I want to ask the question, isn't that the goal of every physician? Like, does the ICU physician doesn't want to improve the quality of life? So, palliative care already embedded in the care that we're providing in all the branches. Coming to the young people, again, I would like to highlight on the unlearning thing because the teaching has been but if we modify the teaching, like pro quality of life, adding that meaningfulness to the life in the medical and the nursing curriculum itself, maybe it will bring great change in the approach towards patient care and that will help a lot. And then including this and creating evidence-based research, that should help you.
We could think that St. John's and Manipal are among the ICUs where there is some degree of maturity in palliative care integration. So, Dr. Anuja, do you feel that have we reached that level of maturity, or are there the level of success, or do you think there are still gaps that needs to be?
Definitely there are gaps. We have achieved a lot over past, 2 decades. I think palliative care has improved. The access to palliative care has improved. There are specialists there.
Hello. So, I think the access to palliative care has improved. However, the main key barriers is we don't have uniform teams, we don't have uniform learning. So, one, it needs to come from medical school, which will again address a lot of basic issues on understanding of palliative care. Second is about continued team meetings, continued multidisciplinary care meetings. That I think is a missing loop in all the hospitals. People work in silos. Every team will be working in their own pattern, but they don't come cross their paths anytime. So I think having multidisciplinary team meetings is extremely useful, and that should be a part of hospital protocols. It should not be that this is my patient, this is your patient. It's a hospital patient, and we are a hospital team, and we are providing care for that particular patient, which also includes not only physician, it would include nurses, it would include the other therapists, like a lot of physiotherapists or occupational therapists or even psychologists in that matter. So there has to be a uniformity in understanding that this is my team and we are doing best possible thing for a particular family who has come to us, for a particular patient who has come to us with a particular problem. So I think that is a missing loop in hospital systems.
Same questions of preparation. In St. John's, do you feel that we have reached a level of integration, or are there still work in, or is it work in progress and some more work needs to be done?
I would say there is work in progress, but still the level that we have achieved is quite a good, I would say. Like we do have timely referrals from the ICU, and then again, ma'am mentioned about once the senior in the team does timely referral, the juniors also pick up, and it becomes a standard. I think has been very helpful in the St. John's setup as well. Having said that, there are still some barriers, and it's work in progress, and I'm really hopeful that we can overcome such barriers.
So I thank all the panelists for participating in this discussion for the last hour. And I really value your perspectives, your thoughts. And again, it is, as Dr. Pratyasha said, that it is never complex, it's always a work in progress, and we endeavor every day to make things better. And research is one way of doing things. So this ICMR contract through which we are doing this workshop is to build that evidence base in this country, because we don't want to bring all the evidence from the high income countries and transplant it here. We are building that evidence base, and our work is to build that evidence base so that maybe 5 years down the line we can tell that this is our evidence, this is our protocols and processes. Thank you everyone, and have a good day.
Thank you, Dr. Naveen. That was very, very systematic and comprehensive cover of very basically who always come a very big set of audience. Since you and Dr. Ashwin are going to be here today, we would like to present the memento. I request Dr. Bhuvana hand over to Dr. Naveen Simon. Thank you. Request Dr. Sonali to hand over the memento. Now, audience, your work will come in recording back and hand over the system to you. Just 5 minutes. All right. Okay, we're going to do a little walkabout, getting up, moving. There are post-its on your tables. Also, my name is Sonali, not posted. How many people?
I'll leave this meeting.
Like the first time I took such
For all?
notes in this format
Yeah.
by listening to other
I'll just
people
leave the
only.
meeting. See,
So
I
for
think
me,
I
many
just want to
tensions,
say that
which I wouldn't
yeah,
have
I think I'm
noticed.
good. And